ERP has historically supported back-end office functions like finance, supply chain, and HR. But today, it's playing a more critical role in helping healthcare deliver better patient care. Stick around to find out why. Welcome back to RPI Tech Connect. I'm your host, Chris Airy, and today we're going to be talking about how healthcare organizations can deliver better patient care through effective resource planning. In this industry, optimizing workflows and staffing isn't just about improving overall business efficiency. It's also about making a tangible impact on patients and improving the work environment for clinical staff. Today, to help explore this topic, I'm pleased to welcome Adam Luff, Infor's VP of Healthcare Consulting. Adam, welcome to the show.
Hey, how you doing, Chris? Nice to be here. Very happy to be here. My favorite subject.
Awesome. Yeah. Well, before we get into it, I'm hoping you can share about a little bit about your background.
So yeah, I've been in the healthcare space in the United States for a long time, and it's been traditionally ERP, back office, etc. But as I've matured into the industry, I realized that ERP on its own is like, it's back office, it's keeping score, it's policy enforcement. I think the more that people can think about what could ERP do for me, the closer you can get to patient care, rev cycle, etc., etc. It's just a much better story, and we can impact that as we're going to discuss today.
Awesome. Well, thanks for sharing that with us. Let's jump into it. So in healthcare, staffing efficiency and workflows, obviously very important, but why do these priorities stand out and how do they have an impact on patient care?
So this is timely. So last week I was at the Becker's CIO CFO conference in Chicago, and there were two subjects. One was all about AI, clinical, etc., etc. But the other thing was the workforce, the management of the workforce itself. And to quote a couple of CIOs and CFOs, there's four particular areas, right? There's the doctors, surgeons, physicians, etc., which nobody really touches that. We don't touch that. Nursing is a big thing. Anything from RNs, LPNs, anybody that's bedside providing care. There is the back office function people that run ERP. They're doing rev cycle, they're doing supplies, etc., etc. And then there's the entry level staff, people that are, they just joined a hospital system. They may be pushing a gurney. They may be cleaning floors. They may be working in the kitchens, catering, etc., etc. Room and board, housekeeping, that sort of thing. And
sure,
it was very interesting that they've seen since COVID, everyone said the aperture has opened of the lens of people to view inside what really goes on inside a hospital. Before that, people didn't really realize. And as a result of that, as we know, we've had this, a lot of people leaving the industry, coming back. But right now, the problem is there's not enough people. You look at any hospital's website, there's hundreds, thousands of jobs open across the board. And at the same time, a few weeks ago, I had I had our top 8 customers in our New York office, and imagine the scene, right? I had a post-it, on a whiteboard. I wrote out things like efficiency, rev cycle, analytics, profitability, etc., etc. And I gave all these chaps a red and a green post-it pad. I said, go and put, the red ones where you got pain and the green where you think you're okay. 7 out of the 8 went into efficiency, workflow management and efficiency, doing more with less. The others were, the analytics are okay, but it's doing more with less. And it just fired me up. It really fired me up. I think there's something a lot to talk about here. We can unpack that, right?
Yeah, what a cool exercise you did there too.
Yeah, it was.
I'm sure they didn't anticipate you telling them go on the board and put your sticker down where you're feeling the pain the most.
They were a little bit.
So it's honest too.
They were a little bit uncomfortable. Let's put it that way. But they got into.
That's how you get to the good stuff.
Yeah. They got into it, and then as we talked, it was it was just apparent that the senior leaders of hospitals, they're up there in their offices, etc., but they understand that this workforce shortage, the fact that they're trying, the crippling bureaucratic burden that's put on them by the payers means that they have to respond. And there's so many things they have to do just to get paid. And you ask a CFO at hospital, what does he care about? ADT. That's what he looks at every day. What am I going to get paid for today? And that's a long road to get to that, to make sure you diagnose properly, code properly, get paid properly, whether it's Medicare or commercial insurance. There's a lot of work involved. And then doing it, understand the cost of the patient encounter, right? What does it really cost me to do this procedure, this encounter? And it's labyrinth. It's labyrinth. But we can help. We can help.
Yeah, and that's what I'm hoping we can maybe talk about this a little bit during our segment today. But you mentioned ERP, traditionally being this piece of technology that supports back-end infrastructure.
Sure.
Things like finance, supply chain, HR. But today it seems like that the role of ERP is evolving, particularly in the role in providing patient care. So I'm wondering, can you maybe provide an example of how this software can support clinicians and improve outcomes?
Yeah, there's a couple of things that are really prevalent at the moment. The first one is the making sure you have the right people doing the right things at the right time for the patient. All right. Now, everyone has an EMR and they do their orders and everything, but it's very difficult. There's very few EMRs that actually do plan the whole process of making sure you've got the right people bedside, acuity, make sure you've got the right nursing with the right qualifications, et cetera, et cetera. So we help with that. As part of our platform, we help with that. So we can make sure that a nurse who's clocked in from her phone, right? She doesn't have to go and clock in on a machine. She clocks in on her phone and straight away she's got a schedule for the day. Okay. So nurses are planned for a day of 8-9 hour shift of what they're going to do during that period. Whereas physicians, it's case based. So a physician would have 5 cases to do a day, where a nurse is the opposite end of the spectrum. So we help a lot with that. And some of the things we do there are making sure we're not going from the second floor to the 5th floor to attend. Okay. Why would you do that? Just simple things like that. Making sure that the right nurse is qualified, and that her qualifications and her credentials, or his or her qualifications and credentials, are valid, that they can actually perform whatever they're set out to do. And then also the other thing we look at in the acuity part of this is, here's a nurse. He or she's really, really good bedside in oncology, as an example, because they're very empathetic, et cetera, et cetera. That might be palliative, et cetera, et cetera. And we can help plan. So point being is, nurse leaders don't have to spend all this time wading through spreadsheets, right? Spreadsheet hell. You talk to any nurse leader, they spend half their shift wading through spreadsheets, figuring out what they're going to do for that shift and maybe the next shift. And when they do their handover, do the shift handover, it's handing over binders. Man, I mean, come on, this is 2024, right?
Physical.
Yeah. Right. Yeah. What are you going to do? Fax them the schedule, right?
It'll be there in 7 to 10 business days.
Yeah, exactly. Yeah, exactly. So that's a big part of it, is that it's making sure that, so there's that side of it, right? But there's also, for the people within a hospital, it's the community of care. So here's a couple of statistics for you. AONL conduct a survey every year, and for the last 4 or 5 years, primo 2 reasons why a nurse quits in the first year, whether they're seasoned or whether it's their first gig. It's number 1, they get the paycheck wrong. How can that be?
That's bad.
Yeah, that's bad, right? And doing it consistently is even worse. So a lot of nurses I need to rely on I want to know when I book my time on my phone, bang, I know what I'm going to get paid. I don't want it to be a surprise when I get paid 2 weeks later. So that's a big thing, right? So we fix that, right? Perfect paycheck is what we do. We put here at Infor, we pay about 1.3 million caregivers a week, right? Perfect paycheck. So that's a big deal. The other thing that is interesting is the second reason that nurses move on is the community and the lack of community. So when you show up first day, first shift, you may have to spend the first 2 or 3 days onboarding with a hospital, binders, et cetera, et cetera. We can help with pre-boarding. So all of that's done before when you get to the first shift, you're ready to roll. So that's a big deal. The other thing is going back to the whole planning and scheduling of staff is right now, a lot of hospitals, it's still post-it pads on a board. Anyone want to do a shift swap with me? Or, hey, Chris, you want to do a shift swap with me? And it's like that is within your little community. But if you can broaden that community and make it easier to do shift swapping, nurse engagement increases. And when nurse engagement increases, when you fix that, it's literally those two things, retention really, really blossoms. I was talking to a big hospital system last week and they told me a couple of things. They've seen a reduction of 30% in churn in nursing.
Wow. That's significant.
It's significant.
That's over like a certain, like a year's time or something?
Since they went live on Infor and
they
attribute that to a lot of things, but the big thing is showing that they care, right? Remember, nurses, they care. That's what they do. Making sure they get paid, making sure that, the shifts and everything, and that community of nursing of what's going in and onward education, et cetera, et cetera. So that's a big deal, right? That's a big deal. The other thing this hospital told me that was just blew my mind was they ran another part of our platform is talent science assessments. So you do this online thing and it figures out how you think, where your mind is, etc. So they did this on the entry level staff, right? So these are all people that were like, they're pushing gurneys around, they're doing transport, moving people around on the floor, etc., etc. It could be janitorial, etc. They found that nearly half of the people that they did a subset test on had a propensity and wanted to learn more and wanted to stay at the hospital. So this is what the hospital did. Genius, right? They trained them themselves in phlebotomy, rad tech, lab tech, path tech, etc., etc. So these people have been trained while they were there working. And now think about that. What does that do to somebody when they care about me? I'm going to stay. I'm going to stay. So they literally wiped out half of their open recs just doing this for the non-clinical care staff. It was amazing, and that just blew my mind. And I'm like, wow, and that's the story I've been telling, right? Because and it's not hard to do. It's having the wherewithal, the tools to do it, of course, which is what we provide as part of our platform. So that was cool. That was a cool story.
Yeah, creating these internal pathways for career development. I can't think of a better tool for getting people, motivated to come to work. And like you said, they're showing the staff that you care about them. You're invested in their future, and you're going to make an effort to, give them the resources to pursue whatever it is that they're interested in.
Yeah.
That's great insight.
And another one that sprung to mind was I was at a big hospital system in New York recently. It's like 24,000 nurses. And a lot of these nurses, they start on the day shift, but they may want to go to the evening shift or the night shift because of family commitments, etc. It was almost impossible to figure that out other than a nurse leader wading through a spreadsheet, etc., etc. So we created a questionnaire for them. And what they did, they managed to move people around and they had less no-shows on shifts, right? They cut their no-shows by like 60%, something like that. That's the worst thing is when the nurse, I'm not coming in today for whatever reason, right? Let's panic, right? Nurse leaders.
Does that happen a lot? Do you know by chance? Is that a common thing?
It happens more than you would think. Nurses tend to rush around with their hair on fire when this happens, right? Especially, and it happens, right? Because, for whatever, it could be kids are sick or whatever it is, or I have to take them to the dentist today. I couldn't get that shift off, so I'm going to take that day off. So then what do? You either try and find somebody else, again, without a system, or you bring in a traveler nurse, right? Which is like 5x the price of a, regular.
So it's probably more expensive.
Yeah, probably more expensive. So on all of these things, and that all goes to helping with the cost of care, but it's also just about caring for the people that work around you. And that's what I see. Hospitals that really focus on that rather than just the bottom line, they're much better places to work for people. They really are. And you feel it when you walk in there. Feel it, right?
Yeah.
Yeah, it's very cool.
I bet.
Yeah, very cool.
Question, you mentioned something earlier about scheduling, and like, what that process used to look like, what it's like now. Is Infor or, modern ERPs deploying any kind of functionality for like predictive scheduling or something? Is there AI in there? What can you share?
Yeah, yes, we are. Talked about it a bit earlier. So the big thing, it's like understanding demand, right? So understanding demand. So here's a good example, right? Big hospital system in Boston, right? They know that when the Bruins or the Red Sox are at home, their ER intake increases, right? Punch ups and fights and people falling over, et cetera, et cetera. So as opposed to a nurse having to remember that, we know we can see that peak in demand and so on and so forth. But also the predictive part this is acuity based scheduling, is really understanding what nurses are good at, what they're qualified to do, and what they want to do. That's
Sure.
it. That's the predictive part. So then when the schedule's published, you get it on your phone, right? Which is a cool thing. It's not on a whiteboard in the nurse's break room where someone might have scrubbed out a name or this Post-it pad. So, and it all just adds up to efficiency. I like to pose the question when I'm talking to nurse leaders. It's like, what's worse for a nurse, no matter where he or she is in her career? What's worse? Spending 2 or 3 hours a shift on admin or spending 2 or 3 hours after their shift on admin? They're both bad.
Oh,
But yeah. And it's like, do you pay for those 2 or 3 hours after shift? No, but it has to be done. And nurses just want to be bedside giving care. Simple as that. Simple as that. Yeah. So we see a big uptick in that sort of stuff. And going back to the Becker's event last week, the predominance of AI in charting, note taking, having a high percentage prediction on what the outcome will be for that patient. We're not there yet.
Oh.
Yeah, we're not there, but that is top of mind. That's what they're thinking about. Like, they really are.
Wow.
Yeah, they're really thinking about that. So you dial in all the things, the diagnosis, what the nurse is seeing or feeling when she walks into the wardroom or whatever. This all adds up to something. All adds up to something. And that may take, I don't know, a few hours, but it can be done, I wouldn't say instantaneously, but a lot quicker. Right?
It sounds like here that, all this functionality and the way the ERP can be deployed today, it's reducing a lot of those admin tasks and saving folks time so that they can dedicate what they want to do, to providing better patient care.
Amen. Yeah.
Focusing bedside.
So,
right?
Another thing we do that is nobody ever thinks about is the discharge process. So, physician walks around, does his rounds, discharges 5 patients at 9 a.m. Those people, if they're really slick hospital, they're out of there by 10. Very rare. They're sat around, they're waiting for their discharge paperwork, they make sure you don't do this, make sure you don't do that. Somebody to then take that person, because, even if it's ambulatory care, they always wheel them out to the lobby area. They're either getting picked up. If not, we can order them an Uber, right? We can do that. We actually do that as well. We pre-order the Uber for them. Okay. So so that's, just little things like that. The other side of it is really interesting is the predicting that when that bed comes empty, you've got to get in there, clean the room, change the bed, turn the room and get it right. Because, it's a cold bed. A cold bed is not earning money in a hospital. So that's the thing. So if that discharge takes 4-6 hours and then housekeeping, room and board show up, that's an 8-hour shift gone. Right. And that's how hospitals think. And also nurses think like that because they know that there's always somebody else. There's always somebody else. So this is all, that's just an example of some of the things we do just to boost efficiency. Make life easier, right? Try and make life easier.
I see how all these things you're mentioning are laddering back up to our initial two priorities here with the efficiency and staffing. So it's great to see that ERP providers like Infor are really providing the tools to empower clinical staff.
Yeah, we are. And it's here's the thing I find that is getting the attention of the operational staff, getting to nursing, right? Getting to people on the floor. Once we do that, tell our story, want some of that. But most of the time, the operational people, they're not thinking about that because they're, finance people, a million invoices a day, suppliers are making sure they don't run out of stuff, et cetera, et cetera. All right. So the other part of this, you asked me this earlier, what else are we doing? The other part of this is AI predictions for what is required for procedures, as an example, right? So procedure, right?
Is that like supplies? Yes. Supplies and stuff?
Exactly. Supplies. Yeah. So you have a preference card, right? So if it's an elective surgery, let's say they're doing, femoral hernia, something like that. There's a preference card, right? And that preference card is 30 things. It's a bill of material. This is what the surgeon wants ready next to him. And it's everything from sutures to instruments and cutting tool, everything. Okay. He wants that there. When the lab techs are rushing around the night before, because that's what happens, their night shift, they're getting their carts ready the night before. If stuff's not there, one of two things happens, right? They're either rushing around to try and find it in the hospital, or if they're in a hospital system in a city, they're driving across town to pick something up, right?
Oh,
last thing they
don't want that.
Pain, right? The worst thing is cancelling the procedure. Yeah, because it's revenue, right? It's revenue. And we help for that. We can look into the EMR, take that order, unpack it and understand what's needed, not just from the supply, but also scheduling, right? We talked a lot about scheduling nurses. That applies to OR as well, etc. So those are the two things that I see really predominantly top of mind for people in healthcare now. It's supplies, don't run out of stuff, buying properly, buying at the right time, making sure it's on the shelf. Most nurses you speak to what do you do when you get on shift? Well, the first thing I do is I go into the storeroom, stuff my pockets with gear. First thing I do. Don't care if there's anything left. I just stuff my pockets with gear because I know that I haven't got time to run about. It's with me. Yeah. And we plan for that. We help plan for that. Right.
This inventory intelligence you're talking about here.
Yeah.
Are nurses and stuff able to see where in the hospital these supplies are being stored and so it's easy to go and get them and they know they can guarantee when they get to that room X, Y, and Z will be there?
Yeah. So here's a story. One of our hospitals up in Montana, Yellowstone country, they deployed our application. They were one of our early adopters where night shift members. So these are community hospitals, maybe 20, 30 beds. They're out in the middle of nowhere. They have a supplies room, but you've got a nurse who's like, okay, I need a Belmont tube. It's like 2 a.m. They've got somebody, been choppered in or they come in an ambulance. I need these things for this emergency case. Instead of having to go in the room, look on the room, they ask Siri, basically. They ask Siri, where is my Belmont tube?
Oh.
Yeah. It's in this location here. Here it is. Bang. And it decrements it, takes it out so that the supplies people know they need to replenish it. Yeah, little things.
Wow.
Little things like that.
So there's a voice assistant capability in the Infor app.
Yeah, that's right. Yeah.
Oh, very cool.
Yeah.
And that's, especially in a space like a healthcare, organization, facility, you probably got gloves on and stuff. So it's easier to probably just speak to your phone somewhere as it is to take off your gloves, clean up your hands and type it in on your phone or something, right?
Yeah,
or go on a computer.
Yeah.
That's awesome.
Yeah.
Really meeting them where they are there.
Yeah. So the last point of that is one of the hospital systems I spoke to recently, again, same thing, I've got gloves on there. How do you activate it? This is what they did. They put an app on the phone so they can just tap their nose on the phone, and it
Oh,
tap it, speak, done. Very, little things like that.
nice.
Little things like that.
Yeah, that's really cool.
Yeah.
It's nose activated, you said, huh?
Nose activated, yeah. But it just happened to be your nose, right? So yeah, it's things like that, and it's what I love to do, right? Listen, we can solve these problems, but we know a lot about them. But come to us; we'll help you solve some of these problems. Right? Our platform is broad. It does, it does all the ERP stuff as we mentioned. Supplies, finance. Finance love us, right? We like to. The finance joke is, why should it take me all month to do my monthly reporting? Not with us. You can get to a weekly close, right? Yeah, really. And then the other part is the interoperability, which is getting information from your EMR. So, question for you, Chris. When somebody is admitted into a hospital, how many messages are created from that EMR that go to all these different places in the hospital? Like, they go to phlebotomy or lab or path. Have a guess.
I guess it maybe depends on the severity of the patient, but I don't know, maybe 10.
Yeah, 25 to 45.
Is 10 a lot?
Yeah, 25 to 45 messages. And those are just so that when you go to pharmacy, that patient exists in the pharmacy record so they can dispense. Yeah.
Got it.
Yeah. And that's something,
That's a lot of.
Yeah.
Go ahead.
Yeah. And people don't think about that, right? People don't think about that.
No, I certainly didn't. And now that you've told me, I'm like, man, anytime I go to the hospital in the future, I'm like,
yeah,
how much stuff is going on in the back end that I just don't even know about?
So we process over 1 billion messages a day on our cloud platform in hospitals in North America. And that's, biggest one is like HCA. I think they do 750 million messages a day, right? Think about that. How many people, admissions. So it's an AD or a T, right? Admission, discharge, or transfer. That's a set of messages that are created that happens so that they can administer. Ultimately, remember what hospitals are all about: getting paid.
Oh,
yeah.
Yeah.
All of this adds up to getting paid better, getting paid faster. All right, that's the gig. That's sadly in North America. Right?
Yep.
Yeah, sadly, yeah.
Well, I appreciate you being candid there.
Sure.
It's true, and being honest is important and transparent. So thank you. We're getting close to time.
Yeah.
Before we wrap up, I'd like to ask my guests if they can impart one actionable takeaway for the audience. What would it be? And so I'd love to hear if you've got one bit for us. What would you share?
Technology is everywhere, and think of industries that have embraced technology to solve complex people interactions, like airlines, right? You check in, you get everything on your phone, done, right? Hospitals need to start thinking like that. That's what they need to start. Think about your patient, not as a passenger, obviously, but think about that patient-centric
experience. Yeah.
Yeah. Think about that. There's always a way to make the journey better for a patient. You make the journey better for a patient. You make it better for the caregivers. Everything else just falls into place. And that's my challenge when I go and talk to execs. Is that what can't you do? And they'll always talk about, well, I can't do analytics. I can't do reporting. So great. If you had better analytics and reporting, what problems would you solve?
Yeah, what would you do with them?
Yeah.
Take it a step further there. It's not enough just to get the data and the reporting. Like, you need to do something with it.
Yeah. What problem?
Brilliant.
Yeah. What's your pain? Yeah. And that's it. That's it. That's healthcare in a nutshell in North America. Right.
Well, thank you for sharing that, Adam. I love that last bit you shared there with us. I'm going to surely share it with my colleagues here at RPI.
Right.
For those of you listening in today, if you have any questions about today's segment or want to learn more about how ERP can help your healthcare organizations, we'd love to hear from you. Mm-hmm. You can contact us at podcast@rpic.com. Again, that's podcast@rpic.com. This is RPI Tech Connect, and we'll see you next time. Thank you, Adam.
Bye.